Right, we want to demonstrate a particularly high venous return in the saphenofemoral junction of the great saphenous vein. You look at the common femoral artery pulsating, we go immediately and notice a very high flow rate in the great saphenous vein. If we measure this, you can see that it's continuous. And looking further down the leg to the great saphenous vein and the inside of the knee, we find ourselves a great saphenous vein. Engage the color Doppler, and you'll notice that the great saphenous vein is pulsatile. We're looking at the area here. Just inferior to the patella in the great saphenous vein, in the right leg. We try and identify a little further down. You'll see there's a small arteriole we're now in the great saphenous vein, which clearly is being fed by an arteriole somewhere. You can measure the flow rate and its obvious pulsation. You look at the probe, you'll notice the probe is lying directly over the great saphenous vein on the right anteromedial aspect. Important to emphasize that there's been no previous endovascular treatment on this vein, and if you follow the vein further down distally, you'll notice the pulsatile nature it is possible that this arteriole and the anterior tibia is responsible for short-circuiting into the great saphenous vein. Pulsation in the great saphenous vein is profound. You attempt to find the arteriole that may be responsible for the arteriovenous anomaly. We are seeing an arteriole in proximity to the great saphenous vein. Could this represent the arteriovenous anomaly in the great saphenous vein? It seems most likely. We're going to introduce a sclerosant into this vein, and this should thrombose the great saphenous vein and prevent the reflux or the connection of the arteriovenous anomaly into the great saphenous vein. So we're demonstrating again that arteriole from the deep circulation that's going to the surface, to the vicinity of the great saphenous vein. And if you look at our saphenous vein, you'll see that it definitely has a pulsatile component. But what you're also seeing is the double lumen over here of the refluxing. If you look at the end of the needle, if you look at the double lumen there, you'll see that blood is ejecting out of the needle, and the color of the blood is surprisingly red, indicating that we have arterial blood mixed with venous blood in the great saphenous vein. If I take the needle out, we'll get even more frank flow at a high rate from the great saphenous vein. Let's go back to the yarn. Looking at the sonar picture, you can see the cannula with a high venous flow pulsatile in the great saphenous vein. I've now occluded the intracath so that there can be no backflow. There's little doubt that there is an arterial connection with the great saphenous vein due to the fact that we have arterial blood in the great saphenous vein and we have a pulsating venous return in the great saphenous vein, as well as the appearance of an arteriole in the area adjacent to the area of maximal pulsation in the great saphenous vein. Okay. Right, we've put the patient in Trendelenburg, and in spite of that, with the gravitationally assisted venous return, we still have a very high flow rate in the great saphenous vein. We're going to introduce, as you see now, with the starionite appearance, ultrasound guided foam sclerotherapy directly into the offending area. The foam sclerotherapy will cause immediate vasoconstriction, produce a thrombus inside the great saphenous vein. We're specifically avoiding the use of endovascular laser here, since the association of thermal injury next to a pulsating arteriole could actually aggravate, in theory, the fistula. Notice the flow seems to have abated. What we are seeing, just to go back to where our cannula is in situ, by wiggling the cannula in the great saphenous vein, we can confirm where it is. You'll also notice that there is still the attempt there to fill with an arterial component. But the flow rate is pushing past. The flow from the arteriole is still pushing into the saphenous vein. So these signs taken all together left little doubt that we have an arteriovenous anomaly in this area, and we're trying to close the venous component without touching the arteriole. We're looking at the great saphenous vein emptying into the common femoral vein in the saphenofemoral junction on the right. Going up towards the epigastric, you can see a very high venous flow rate that is present in the junction. The reason for this is unknown. Now, if we trace the great saphenous vein back to where we've just come with our previous saphenofemoral junction, there's our great saphenous vein. The high flow rate has reduced enormously following the injection of the arteriovenous anomaly in the anterior medial tibia. But it still hasn't solved the problem of why we have such a high venous return superiorly what we want to emphasize is that the color of the leg has become enormously better just by closing the arteriovenous anomaly, both on the left and right hand side. We used to have a dark reddish blue appearance of venostasis, venous congestion, and having closed that area, the color of the legs has become absolutely almost perfectly normal. We're going to give this a 6 months chance. We're going to follow up with the compression stockings for a week, and within 6 months we'll come back and see whether the anomalies have closed.